Hello, and welcome to this Ethical Dilemma in Science. I'm John Hoffman, a professor of biology at Arcadia University in Pennsylvania. The scenarios in this collection examine a potentially controversial science-related topic in order to better understand the basic science concepts involved and the associated ethical debates. The goal is not to decide upon a final concrete and universal decision about the use of science or technology, but to stimulate a discussion considering the different viewpoints in order to better understand the diverse perspectives involved. In this ethical dilemma in science, we will examine human subject protections, focused around the question of using clinical research to evaluate vaccine safety and effectiveness. Now, in order to understand vaccine safety and effectiveness, we must first examine the history of the modern vaccination process. Now, the modern vaccination process began in 1796 with the actions of English doctor Edward Jenner. Now, during this period of time, smallpox was recognized as a deadly virus, deadly disease that spread throughout society. And those individuals that got it often got very, very sick, and many of them died. Along this period of time, there was also the observation that dairy maids who worked intimately with cows, milking the cows, feeding the cows, working with the cows day in and day out, seemed to be protected against the smallpox virus. And there was this feeling that they were exposed to a milder version of the virus. This milder version would be cow pox, which came from cow udders, that somehow gave protection against the smallpox virus. So what Edward Jenner did is he collected samples from a cowpox lesion from a dairy maid and then injected the sample into an 8-year-old boy. And this is represented in this painting by Gaston Melengue from about 1894. The boy that was injected with the materials from the cowpox lesion got sick, developed a fever, lost his appetite, felt discomfort, but ultimately recovered. Now, what Jenner did next is, ethically questionable at its kind of most favorable viewpoint. But Jenner injected the boy with smallpox virus. Now, keep in mind that this virus would normally have caused this child to get very sick or possibly died. But in this case, the boy was protected against the smallpox, this very virulent disease-causing virus, possibly or expectedly because of the exposure to the cowpox material. And so because of this, Jenner was recognized as the father of immunology. Now, it's important to recognize that he wasn't the first person to use this process. There are written accounts of a process of variolation, which is described as inoculation in Great Britain during the time of Jenner. But basically going back to about 1550 in written accounts in China, and possibly in less documented traditions going back to about 1000 AD, where they would infect people with a little bit of material from a smallpox lesion in the hopes of protecting them against a full-blown disease. So Jenner's work is definitely ethically questionable, but could it happen today? This is going on, 200 years ago, 220 years ago, about the start of the 1800s. And so we take a look at it. More recently, taking a look at the 20th century, we find all kinds of examples of unethical experimentation on human subjects, especially during World War II. And so everybody's heard, or at least most people have heard about the experiments on prisoners, taking a look at hypothermia, weapons testing, creation of artificial battle wounds by individuals that were vulnerable to the Nazi regime in Germany. And many of these people, these doctors conducting the research, were brought to justice in the doctors' trials as part of the Nuremberg trials at the end of World War II. Kind of less known is the fact that these types of atrocities occurred in other areas as well. Unit 731 was a unit of the Japanese Army that did biological and chemical warfare research in occupied China. Again, working on vulnerable populations and did weapons testing, testing flamethrowers. And the photograph from the World War II archives On the right-hand side of this one, we're looking at a test subject there being exposed to biological weaponry, basically exposed to bacteria. But you can argue that these atrocities happen in war, and war is filled with atrocities. But again, taking a look at the United States after World War II, we can find numerous examples of unethical research, especially from our perspective today. Again, different examples include the Tuskegee syphilis experiment that gets a lot of attention. It ran from 1932 to 1972, in which over 400 Black male sharecroppers that were infected with syphilis had the treatment withheld from them. Penicillin was available by 1943, but the researchers doing the study wanted to look at untreated syphilis. And so for an extended period of time, they looked at the progression of the disease. Other examples of that in this area, taking a look at the Holmesburg prison in Philadelphia. In the book, Alan Hornblum wrote Acres of Skin. Took a look at the cosmetic testing radioactive materials and mind-altering drugs from the 1950s to the 1970s on a vulnerable population within the prison system in Philadelphia. And then finally, the Willowbrook State School was a school, as an institution for children with intellectual disabilities that did extensive hepatitis experiments, including infecting children with the hepatitis virus in order to learn about how the virus progressed into the disease and how that disease was spread. Now, in the early 1970s, this and other types of examples of research gained attention, and there was a public outcry. So in 1974, the National Research Act created the National Commission for the Protection of Human Subjects and Behavioral Research. Now, this was an advisory group that originally started out to establish boundaries between research and medical practice, determine, research is kind of learning information that would be generalizable, that could be applied to other individuals, but medical practice would be the treatment of a single patient. Now, this commission has changed over a period of time. And at this point, the most latest version of this was the Presidential Commission for the Study of Bioethical Issues that President Obama had in place from 2009 to 2017. This group was dispersed during the Trump administration, and recording this in 2021, there are numerous calls for the Biden-Harris administration to appoint a new bioethics committee. Now, if we take a look at what the commission did, they issued the Belmont Report in 1979, which came up with basic principles for human subject protections within the United States. Now, these basic principles include respect for persons, recognizing that we should allow individuals to make a decision for themselves as to whether or not they are willing to participate in the research study. And related to this, we need to take individuals with limited ability or diminished autonomy, limited ability to make their own individual decisions. They need to be provided with additional protections. The Belmont Report introduced the concept of beneficence. With the concept of beneficence, you're basically looking at do no harm. You want to maximize the possible benefits of the research while minimizing the possible harms or risk associated with it. And then the final principle was the principle of justice, the idea that the burdens and the benefits of the research should be distributed equally. Previously, the research had been done on poor, infirm, prisoners, basically vulnerable populations that were used to learn information that was applied, and the benefits were applied to other groups of individuals. Now, within what the Belmont Report established would be this idea that we need to have institutions or a mechanism in place in which we would evaluate and approve human subject research before it starts. And so what we have are going to be institutional review boards at colleges and universities, at research centers, at hospital systems that evaluate a research proposal in relationship to the Belmont Report and look at how they apply these principles. Now, within the application of these principles, there's a concept of informed consent. And this is the idea that subjects should be provided with information about the research procedure, purposes of the study, the risks and anticipated benefits, and have the ability to kind of learn about what it is that they are actually volunteering for. They need to be able to receive this information in a format and a level that makes sense to them. And they also have to be able to make this decision to participate or not, free from coercion and undue influence. You basically don't want to bribe people to participate in your research studies. The institutional review boards, or the IRBs, also look at the risk-benefit assessment with the idea that you want to reduce the risks or reduce the harms as much as possible and maximize the benefits that are available. Now, this doesn't mean that high risk, high harm research is not possible. It just means that the justification for taking these higher risks needs to be established and supported and approved by the IRB, the Institutional Review Board, before the study can begin. And then finally, again, because much of the research in the past has been done on vulnerable populations, we need to have the ability to select the subjects of research in a way in which that we are distributing the risks and the benefits of the individual evenly throughout society. So we shouldn't benefit the population at the expense of somebody else. And we also need to be recognized that there are social justice implications in the selection of these research subjects. And so no category of subjects should bear an unequitable distribution of the harms associated with it. And this is especially important when we take a look at oftentimes previous to this, vulnerable populations or populations of social, racial, sexual, or cultural biases would be impacted in these selection of subjects. And so, we need to be able to conduct this research in an ethical way. So the question then becomes, how do we apply this to our question of determining whether or not our vaccines are going to be safe and effective? And so human subjects are going to be recruited into clinical research trials. And so the Food and Drug Administration defines clinical research trials into a variety of phases. The first phase 1 trials, are how does the drug or intervention affect the body? And so they look at 20 to 100 volunteers. Usually, this will be healthy volunteers in order to be able to understand how the body responds to the drug and determine the safe dosages that are available. It is possible that perhaps we'll be looking at individuals with a condition if the drug is specifically for a condition such as cancer. In the phase 2 trials, assuming that everything goes well in the phase 1 trials, we expanded a little bit to determine, does the drug work under ideal circumstances, ideal conditions? And so you take a look at the drug effects with about 700 individuals, often with individuals that have the conditions, but in very controlled environments. And so we're looking at, does this work well under ideal circumstances, and are there any short-term side effects? Again, assuming that the phase 2 trials go well, in the phase 3 trials, we take a look at whether or not the drug works well in real life. And so you expand this research out to look at different populations, hopefully a diverse population, and oftentimes compare it to standard treatments if standard treatments are available. Now, the purposes of the phase 3 studies are to determine the efficacy of the drug, monitoring for adverse reactions that may occur from kind of exposure to the drug. And they're basically used by the Food and Drug Administration to determine the safetiness of the drug. Phase 4 drugs, phase 4 clinical trials is often referred to as post-market safety monitoring, in which the drug companies continue to evaluate whether or not the drug is going to be effective long-term, kind of ensure that there aren't any long-term risks associated with it, adverse effects, things like that that could be occurring. And so from this perspective, we go to the question of how do we use this to show that vaccines are going to be safe and effective, especially within a diverse population. Now, when we take a look at minority or diverse groups represented within clinical studies, what we can see is that in a lot of studies, and this is the results of a 2021 study taking a look at clinical research trials in 2015, or published in 2015 and published in 2019, what we can see is that the racial, socioeconomic status, and sex are often going to be fundamental determinants of health. Race, socioeconomic status, and sex often are going to determine how well an individual is going to recover from a disease. Now, recognizing that and then seeing it in the scientific literature are two different things. The demographics in research studies, the demographics of the subject population, are only published about a third of the time. And when they are published, the minority groups are consistently underrepresented. And so according to the census results, the white population is about 71%. And this is taking a look at 2015 in the green and 2019 in the kind of lighter green, I guess. We can see that, we're upwards of 75 or above 80% for the mean. And so on these box plots, the line is representing the mean. The box above it is kind of that 25 or that quartile, 25% of the studies are going to be in that area. 25% of the studies below the mean are going to be kind of in that area. And then looking at kind of that additional quartile going up to the top there. So that'd be 75 to 100% of the studies. And then going down here is taking a look at kind of the lower population. So the lowest quartile being present. So when we take a look at this, we see that the white population is consistently overrepresented, and then the minority population is significantly underrepresented. Now, keep in mind that in 1993, the National Institutes of Health implemented a law that said that women and members of minority groups and their subpopulations must be included in all NIH-funded clinical research. This was further kind of reinforced in 2009 when the National Institutes of Health implemented an internal task force to determine best practices. But still, we're seeing this underrepresentation occurring. Now, when we take a look at this, again, in relationship to the COVID-19 pandemic and the need for vaccines and effective vaccines across all populations, we can look at the effects of these different disparities. We're looking at the disease load, in essence, that are disproportionately higher in minority populations. And so a number of studies in late 2020 and early 2021 took a look at different populations and their statistics for COVID-19 related infections, hospitalizations, and deaths. And in comparison to Caucasian statistics, we can see that African-American, Black individuals, as well as Hispanic individuals, have a much heavier disease load. They have much higher infection rates, higher hospitalization rates, and excess deaths in comparison to Caucasians. In contrast, Asian populations are relatively similar. Now, there could be a whole variety of other factors involved with this, but it does show that the disease load is different across different populations, at least within the United States, and we could extend this to populations around the world. So this introduces our ethical dilemma in science. How do we ensure diverse representation of human subjects in these very important clinical trials. We need to learn about the individuals and how these drugs are going to interact within their bodies, because we are not all physiologically the same. We have different kind of characteristics and traits within our bodies, which determine how well or how weak a drug treatment would be within our own individual bodies. And so what we need to think about, what are the barriers to diverse representation in clinical studies? How do you balance the need for diverse representation without resorting to exploitation of a vulnerable population? And then the last question, how do we provide incentives for participation without being coercive? So again, an opportunity for discussion time. So if you would like, you can pause the video here and then come back with a little bit more information. So again, coming back and taking a look at this, there have been numerous individual and societal barriers that have been identified that limit diverse participation in clinical trials. Now, some of these are individual skepticism within populations, within kind of groups within the United States. And so the skepticism can be represented with a distrust in the researchers that are conducting the experiment, and with good reason. When we take a look at some of the atrocities that have occurred within, the Holmesburg prison, the Tuskegee syphilis studies, the Willowbrook State School, lots of reasons to be, potentially distrustful. We need to, build trust. A discomfort with inherent uncertainty of trial participation. What's it mean? What am I signing up for? Does this mean you can do anything to me? What are the limits? And then language discordance. Again, we need to be able to we need to be able to describe what is going to be involved with these clinical trials in a way in which the individuals can understand it and make an informed decision on their own about their willingness or not to participate in these studies. And so we need people that can communicate well and, to be honest, look like the subjects that are being recruited. They're not all, a certain category, a certain demographic kind of going out and recruiting individuals from these diverse populations to participate in the studies. There are also going to be societal barriers in place, and so multi-level barriers that are present. Oftentimes, diverse populations have limited access to transportation and a difficulty to get to that test site. They may have inadequate insurance coverage, and because of that, their own individual health care may not be as good, and they may not learn about these clinical trials from their primary physician or from their healthcare provider. And then also, and probably most importantly, there are often going to be competing obligations that limit the time for trial participation. How are you going to get somebody to, take time off work to participate in a research study if, taking time off work means their income takes a hit and they potentially, are not going to have the money to pay their bills because they're not working and being paid for that. So lots of things, hopefully, that you will see and discuss in this ethical dilemma in science. Thank you for listening to this. I will post some links for additional information within the description below. So thank you and have a great day.